We'll start our program with welcome address by our President, CMS Dr. Shanti Gunasingh ma'am. Ma'am is President, Chennai Menopause Society. She's past President Oxy, former Director and Superintendent IOG. She's a former HOD of Keelpark Medical College. Served as Project Director and Center of Excellence for Tubal Microsurgery for 6 years. She's the past President of Women's Doctors Association, Tamil Nadu. She's conducting adolescent health programs. Over to you, ma'am.
Thank you. Good evening to one and all. It is indeed my pleasure to welcome you all to our to yet another webinar by Chennai Menopause Society on bone health in midlife and beyond. We know that bone health is crucial to well-being in midlife and beyond. And invariably, a problem in bone health leads to untimely demise also in menopause. So because of all, and we also should be aware that it is to a certain extent preventable by interventions starting right from adolescence. So we have, so we decided to have a webinar on bone health to empower our menopause practitioners to tackle such women effectively. I have great pleasure in inviting Dr. Lakshmi Srikande, Joint Secretary of IMS, and who had done great job in ICOG too. And she is our chief guest, and who will be releasing our model, that is our e-newsletter, 14th edition of our e-newsletter. We have been consistently releasing it and sharing with everybody. And it is also my pleasure to welcome Dr. Sandhya Dikshit, President of Hyderabad Menopause Society, whom I always see to be as a person who's very much interested in quiz. So she, prior to becoming president, she used to win a lot of IMS quiz programs also. And have great pleasure in welcoming the entire faculty. Our eminent chairpersons, Dr. Jaya Vijayaraghavan, Dr. Vijaya, Dr. Anuradha, and Dr. Kalaivani, and our eminent speakers, Dr. Bharani, Dr. Meera, Dr. Jayashree Gopal, and Dr. Sendin. Dr. Jayesh, it's really a pleasure to have our senior CMs, Chennai Menopause Society members, Dr. Jayashree Gajaraj, our founder president of Chennai Menopause Society, and Dr. Nirmala Jayasankar, my dear friend and president of SOFC. So it is indeed a nice start to our program. Let us get along with the program.
Thank you, ma'am. We shall start the event with the tradition lighting the lamp.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
I request our EC member, Dr. Divya. She's the lead fetal medicine and gynec imaging, high fertility Chennai, to recite our midlife prayer.
Yeah, I think Sahiti is making arrangements for the lighting of Kuttuvelakku. Please carry on with that. After that, Dr. Divya will give the midlife thing.
We pray to God to give us grace to accept the midlife physical changes and gently renew our strength, guide our heart, our mind, and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond memories of their life, and also for those sitting in the doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others.
I request our President CMF to introduce our Chief Guest of the day.
Thank you, Divya, for the midlife prayer. So I have great pleasure in introducing Dr. Lakshmi Srikande, who is the immediate past chairperson, ICUG. As I told you earlier, she had really done a great job as its chairperson, national corresponding editor of Jogi, and national corresponding secretary, Association of Medical Women, Joint Secretary IMS, Vice President-elect ISOPAP 2016-17, President ISOPAP Vidarbha Chapter 2019-21. She was Chairperson of IMS Education Committee 2021 to 23 and Chairperson of Fertility Enhancement Committee in ISOPAP, was a member of the Suffolk Education Committee and President Association of Medical Women, Nagpur, President Menopause Society, Nagpur earlier, and Senior Vice President Foxy 2012. At that period also, I had the fortune to know her, and she was really a great worker, and President Nagpur OB-GYN Society 2005 to 6. She has received innumerable awards and honorary FRCOG, Nagpur Ratan Award, Bharat Excellence Award, Women's Health, Best Committee Award. She has publication to her credit and has done a lot of public health programs. Dr. Lakshmi Srikande, please. I request you to give your chief guest address and also release our model menopause associated disease awareness letter, 14th edition.
Thank you. Thank you so much, Dr. Shanti, for your kind introduction and also for the kind invitation. I am so happy to be amongst you all today for such an interesting and I must say very important webinar, because bone health, everyone will agree that it's a very vital component whenever we are talking of perimenopause and our menopausal woman. I was just going through the statistics, and in India, there's so many women who are suffering from osteoporosis and all the ill effects of osteoporosis. So happy to note that Chennai Menopause Society is such a vibrant society, doing so much awareness programs in this regard amongst your patients, amongst your own society members, because even many of we doctors are having osteoporosis and sarcopenia. So very important aspect, you are having this webinar, and I'm so happy to see and meet Dr. Shanti yourself. You are the president. My dear friend Meera Raghavan, I can't see her, who is here, and your treasurer, none other than Dr. Dhanalakshmi. So I suppose you must be having a lot of Lakshmi in your Chennai Menopause Society accounts, and I'm happy to see Dr. Jayashri Gajraj, Dr. Nirmala, who are very senior, and I can see Dr. Kalaivani, she was also here. I can see many, many familiar faces, and keep continue doing your good work, because I know we all are basically OBGYNs. We do lot of obstetrics, lot of gynecology, but when we ourselves reach 40s, we realize the importance of the health of perimenopausal and menopausal woman. So happy to be here, and I thank you all for inviting me again. Thank you.
Thank you, ma'am.
Please post the newsletter, Madam can
Yes.
read.
Yes, yes. The title is Menopause Association Disorders. Very good. So this is for patients, I believe.
Yeah, this is for our menopause practitioners, which includes everybody. The OG,
Okay.
nurses, other
Paramedics also. Yeah.
medics, also. So for everybody, it is of useful, it is of much use.
Good.
We have things like our Know Your Society, then Know Your City, our own type, okay? And of course, Kolam Corner, because Kolam is famous in South India. And awareness about healthy aging. All these are routine, and of course, Sudoku, inevitable Sudoku to sharpen our brain.
Yeah, yeah. And the topics you have chosen are very, very important. And the speakers, I can see the mix of orthopedicians, the endocrinologists to speak on the bone health. And I am really here, Meera, to listen to your talk, ergonomics, because that is also very important. We all are multitasker. We try to please everyone except ourselves. So apt topics, apt speakers, and I am here with you all till the end to listen to each and every speaker.
Thank you, Madam.
Thank
Rajiv?
you, ma'am. Thank you, ma'am. I request the president to introduce our guest of honor, Dr. Sandhya Dixit, ma'am.
I have great pleasure in inviting Dr. Sandhya Dixit, who is our guest of honor. She is the president of Hyderabad Menopause Society and retired professor of OBGYN, Government Medical College, Telangana. Master trainer for PPIUD, IUCD, Safe Abortion Services, Newer Contraceptives, Dakshata and BMO, and PG and UG teacher for more than 2 decades and presented various papers and has lot of publication to her credit, and recipient of Abdul Kalam Medical Excellency Award. We want to liaison with our fellow societies also and get to know all our fellow IMS members. So this is part of that. Welcome, madam.
Thank you. Thank you, ma'am. Thank you so much. I am really overwhelmed and I already feel divine by your lamp lighting picture. It was wonderful of you to, seeing the God, the lamp lighting, the music. It really started it off very well. And the column and your know your city, know your IMS, all those things are, very, very creative, very nice. And all the topics, as Dr. Lakshmi Shrikante has already told, all the topics are important. And it is high time that we have been, it has become one of the major public health hazard among the menopausal women regarding osteoporosis and deficiencies and bone health, which are inevitable, but there are ways and means where we can improve the bone health by creating awareness, which not only for non-medical persons, but I feel even for medical persons, importance of bone demineralization or bone mineralization how up to 3 decades we have to, improve our bank account of calcium deposit, how it is going to reduce afterwards. All such things should be taught to our junior doctors and practitioners as well. Repeated CM is, I think, is the only answer where we have to learn, unlearn, and learn again. And any number of CMEs regarding on bone health, osteoporosis, calcium, vitamin D deficiencies, and the treatments and supplementation are insufficient. Repeatedly, we have to be at it again to reinforce ourselves. I think it's a wonderful seminar, and thank you all the doctors from Chennai Society, and Madam particularly to you, Gunasinghe ma'am, and Rajalakshmi, who has called me and contacted. Thank you so much. I am very much interested to listen to the proceedings now. Thank you, ma'am. Thank you so much.
Thank you, ma'am. We'll move on to our webinar. I request our chairpersons, Dr. Jaya Vijayaraghavan.
Rajalakshmi, ma'am.
What happened? Hello?
Yes, ma'am.
Shanti?
Yeah, you can introduce Madam Raji. Okay. If she's
Ma'am, yes, ma'am. Sorry, ma'am. Disconnected, ma'am. Jaya HOD for the past 9 years. She's HOD of Ramchandra University. She has guided many undergraduates and postgraduates. She has guided many PhD students. She is a co-coordinator of obstetric medicine at Sriha. I welcome you, ma'am. I also take immense pleasure in welcoming Dr. Vijaya, ma'am. She is HOD and Professor ESI Medical College and Hospital, Chennai. She is the former Director, Institute of Obstetrics and Gynecology, Madras Medical College. She is the President, Oxy, Chennai, and member of Oxy Medical Education Committee. Her special interest in high-risk pregnancy, infertility, and laparoscopic surgery. I welcome you, ma'am. And Dr. Anuradha, ma'am, I take pleasure in welcoming Anuradha, ma'am. Ma'am is the professor and HOD, SRM Medical College and Research Center. She has more than 19 years of UG and 14 years of PG teaching experience with 30 publications in both national and international journals. She's an organizing chairperson for SRM or OGCon National Conference. Her field of interest is high-risk pregnancy endoscopy. She is a guide for postgraduate thesis and PhD guide. She's a member of Oxy, Foxy, IMS, and AMASI. Over to you, ma'am.
I request the chairpersons to take over.
Yeah. I now call upon Dr. Barni Vijayaraghavan. Barni Vijayaraghavan is actually she's a senior resident at SRMC, but however she did her MD and DNB, MD DGO from MMC and DNB from Apollo Hospital, and she's a member of the Safe Motherhood Committee, and she has received an award from Tamil Nadu Ministry of Health and Family Welfare for outstanding performance in maternal and child health, and a best resident of Apollo Hospital. She will be talking to us about evaluation and screening for bone health. We all know that osteoporosis is a major non-communicable disease, and it is a silent killer. So unless we recognize, evaluate, and try to screen women in midlife for their bone health, we will not be able to recognize, as they present with very vague complaints. And so it is important to evaluate and screen women for this for bone health. Over to you, Dr. Barni Vijayaraghavan.
Thank you so much, ma'am, for that kind introduction. I'll just share my screen in a moment. I hope my screen is visible.
Yes, ma'am.
A very good evening to one and all, and thank you so much for this opportunity. I'll be speaking about the evaluation and screening of bone health, particularly in menopausal women. We know that after a certain age, maintaining a healthy body weight, having a good diet, regular exercise, soaking up as much sun as possible, and avoiding addictions like smoking and alcohol is very important to build better bones, particularly for our menopausal women, because these women are at a higher risk of developing osteoporosis or a condition where there is low bone mass, microarchitectural disruption, all of this leading to something called fragility fractures or fractures that occur with low or minimal trauma. And these fractures particularly occur in the spine, hip, and wrist, and this can lead to a lot of morbidity in these menopausal women. We know that a lack of estrogen leads to a lot of problems in this midlife and menopausal women. Of particular interest for us is osteoporosis. While a subclinical disease and a bone weakness starts with the onset of menopause, it is evident as clinical osteoporosis leading to fracture beyond the age of 60 years. So the burden of osteoporosis is increasing because our women's life expectancy is increasing. So is the burden of osteoporosis. Up to 50% increase in costs due to treatment for osteoporosis is projected by 2025. So we need convenient as well as reliable screening tools to ensure that we reduce the clinical and economic burdens that an aging society is posing on our healthcare system. Now, we know that there are many non-modifiable and modifiable risk factors for osteoporosis. Being a woman, having an advanced age, being an Asian woman, all of these predispose to them to developing osteoporosis, along with a low peak bone mass, low BMI, a personal history of fracture, and a family history of osteoporosis. Add to it alcohol use or a chronic corticosteroid use, low calcium, smoking, sedentary lifestyle. All of this is going to put her at a higher risk of developing osteoporosis. And we already know that bone mineral density is best assessed using a DEXA scan, which is the gold standard. But then screening by a DEXA may not be feasible at all times because there is a higher cost, there is poor portability of the DEXA machine, and there is an increased risk of exposure to ionizing radiation. So is there something else that we can do? As we were always taught, our evaluation always begins with clinical examination. So we've seen a lot of these old women. We see women like this coming to our OPD. We look at their height, weight, balance, BMI, gait. We look for kyphosis, the dowager's hump, and you have certain clinical signs which can predict the risk of thoracic fracture or lumbar fracture. For example, inability of the woman to touch the occiput to the wall, or your inability to insinuate four fingers between the lower rib cage and the anterior superior iliac spine. All of these could be indicative of loss of bone mineral density in these women. Now, do we have any screening tools? Do we have any risk assessment tools? Yes, there is the popular FRAX score, which was developed by the University of Sheffield. It is a computer-based algorithm, and it predicts a 10-year probability of getting a hip fracture or a major osteoporotic fracture. So if the woman has already done a DEXA scan, we can use her bone mineral density or the T-score to predict the risk of developing fracture. Suppose she's not had a DEXA scan, we can use her clinical risk factors and her body mass index to predict the risk of hip fracture. So this is an online tool. This is just an example of how this questionnaire will look. And these are very simple questions. And from basic history taking, we'll be able to fill this tool. I'll just play a short video of how this is done. So you can go to this website, frax.chef.ac.uk. So once you go into this website, you will see various, you can choose the region of interest, for example, India, and you'll have this questionnaire where you can key in all these data, the age of the woman, the weight of the woman, any history of fracture, any previous hip fracture, smoking, alcohol, all of these things. And if she's done a DEXA scan, you can enter the T-score as well. And this will give you a risk. Once you've entered the score, this will calculate a risk of major osteoporotic factor based on her bone mineral density and a risk of hip fracture. Now, this is what it's going to give. It's going to give the probability of major osteoporotic fracture in a woman, either using the BMI or using the bone mineral density. Now, for example, if you say that there is a woman who has no clinical risk factors, but she's about 50 years of age, and she's done a bone DEXA scan, and the bone mineral density is minus 2.5. The T-score is minus 2.5. So she's got a risk of getting osteoporotic fractures to up to a probability of 2.4. Similarly, if you have a woman whose BMI is 20, she's 50 years of age, with no other clinical risk factors, there is a 1.3 is the probability of her developing a major osteoporotic fracture in the next 10 years. So this is how the FRAX score is useful in determining whether a woman is at a high risk. So once we determine that, then we'll be justified in proceeding with the DEXA scan in these women. And if these women fall under the low risk category, we can reassure them, give them lifestyle advice, probably consider hormone therapy. And when they fall in a high risk or a very high risk category, then we need to treat the osteoporosis either using oral bisphosphonates or inhibitors of bone resorption. Another very simple tool, much simpler than the FRAX score, is this osteoporosis self-assessment tool, or the OSTA. So it's a very simple formula. It just uses the current weight of the patient and the age of the patient. And for Asian women, there is about a 91% sensitivity. So it's a very good test in that sense, but it only has a 45% specificity. So you use the weight of the woman in kg, age in years, subtract both and divide by 5, and categorize them as high risk, moderate risk, or low risk. Now, for example, this is a case of a woman who is 60 years of age and her body weight is 50 kg. She comes in the moderate risk group. So if she's at a moderate risk group, she's got a 15% chance of developing osteoporosis. And if she's in a high risk group, there is a 61% chance. And if she's in a low risk group, there is a 3% chance. So based on her risk stratification, you can decide whether you're going to give her lifestyle modification, or you're going to give her bisphosphonates, or go ahead and do a DEXA scan. And DEXA scan, as I told in the beginning, dual energy X-ray absorptiometry. This is the gold standard. So it uses two X-ray energies, one for the bone mineral and the other one for the lean muscle and the adipose tissue. Now you calculate something called as the T-score used after measuring this bone mineral density. And if the T-score falls between -1 to +1 standard deviation, that's a normal bone mineral density. She falls in the osteopenic category if she's between -1 and -2.5 standard deviation. Osteoporosis if the T-score is between lesser than -2.5 standard deviation. And it's severe osteoporosis when she's got a T-score in the osteoporotic range as well as a fracture, clinical fracture. Now, this is a gold standard, and it's far more better than a plain X-ray, because in a plain X-ray, you need at least 30% bone loss for it to be visible on a plain X-ray. So this is far more effective. So if a 1% standard deviation fall in the bone mineral density accounts for 10 to 12% in actual fall in bone mineral density, which is a 2.5 to 3.5 times more chance of developing a fracture. And the fracture commonly, the sites used to measure bone mineral density is the lumbar spine and the hips. These are the sites which are most likely to fracture. And if it is an extremely obese woman, you can use the forearm to calculate the bone mineral density. So who are we going to screen? Any woman who's more than 60 years of age. And if she's a younger woman, if she's got other clinical risk profile factor, for example, there's a low body weight, there's a prior low trauma fracture, she's on high risk medication, she's a smoker, she has more than 3 alcoholic drinks per day, or anybody who's had a fragility fracture before, or who's been on chronic glucocorticoid therapy, or if you have an individual who's a known case of osteoporosis who's been on a pharmacological therapy, you will want to monitor her using a DEXA scan. It's also a good idea to stratify the risk of this woman, do a preliminary FRAX scoring, try to find out if she's at a high risk of developing a major osteoporotic factor. For example, if it is 9.3 and more, you're justified in doing a DEXA scan. Now, this is something that's gaining a lot of popularity nowadays. A calcaneal quantitative ultrasound. It's an alternative approach for assessing bone health and identifying osteoporosis. It's gaining popularity primarily because it is cheaper. It can be done using a portable ultrasound machine, and it's free of ionizing radiation, and it's easier to handle. So you can even do it in a camp basis or on an outpatient basis. But the flip side of this is it's got a very low sensitivity. It has a high specificity, but a very low sensitivity. So it seems to be an attractive alternative It may be helpful in pre-screening, like how our Prax is used for a pre-screening tool. This can be used for a pre-screening rather than replacing our gold standard DEXA scan. Now, once you've picked up that a woman is on osteoporotic range, how are you, when are you going to treat her? If she's got a vertebral fracture or a non-vertebral fracture, naturally we are going to treat her. And any woman who is more than 50 years of age with a T-score less than -2.5, you're going to treat her. And anybody who falls in the osteopenic range, that is between -1 to -2.5 standard deviation T-score, but then there is a more than 3.5% risk of developing hip fracture according to your FRAX score, or more than 10.5% risk of developing a major osteoporotic fracture from your FRAX score, you may want to treat her, though she is only in the osteopenic range. And if she is a diabetic woman, you may consider reducing the T-score to -2.0. Once the standard deviation is -2.0 or less, you may want to treat somebody who's type 2 diabetic. And what are we going to treat them with? With bisphosphonates, alendronate, trisinronate. They may have to be continued for 5 years. Or if there is a GI intolerance, you may have to give zoledronic acid for 3 years or denosumab after an endocrine review. Now, how often are we going to follow up these women after they've got a DEXA scan? Now, if she falls in the normal bone mineral density range, you can do the DEXA scan once every 10 years. That is, if it is more than -1.5 standard deviation. Between -1.5 to 2, you have to repeat the DEXA every 5 years. -2 to -2.4, consider repeating it every 2 years. And if she's taking treatment, if she's choosing a bisphosphonate, if her DEXA is a T-score is -2.5 or lower, and she's taking bisphosphonates, you can repeat the DEXA scan every 5 years. And if she's not taking treatment, she can have it every 2 years. And if she's got comorbid conditions or she's already got fracture, you'll have to repeat the DEXA scan every 2 to 3 years, even with treatment. Thank you, ma'am. So you do your best when you feel your best. Take care of your bones. Do what it takes to evaluate, get yourself screened and prevent osteoporosis. Thank you, ma'am.
Yeah, very good, doctor. Very nice. Very nice presentation. Fantastic.
Thank you.
Yeah, the fracture risk and how to take well. Done well. Congratulations.
Thank you so much.
Work ergonomics for doctors.
I would like to, good evening, one and all. I would like to invite Dr. Meera Raghavan, ma'am. She's a consultant urogynecologist and robotic surgeon, Apollo Hospitals, Chennai. Madam is Secretary, Chennai Menopause Society, Executive Committee Member of OXY, Core Committee Member, Urogynec Subcommittee, FOXY, Core Committee Member, PEPA, Background ANFOG, Core Committee of GIPS, Core Committee RCOG, Fellow Representative of IRC RCOG, Member Specialist Committee, National Board of Examination. She is a MRCOG trainer and examiner, recipient of various gold medals in both UG and PG, and she has publications in both national and international journals. Welcome you, ma'am. Over to you, ma'am. Thank you.
Thank you all, and happy to meet you again in a webinar interface. We all advise our patients, but do we practice the same? And most of us do have these aches and pains, which are very debilitating and limiting as well. And what do we do about it to prevent them in the first instance? So that is why we thought we will have one for ourselves as work ergonomics for a gynecologist and obstetrician, but I've included most of the faculties as well. So we're going to go through what is meant by ergonomics and why we need ergonomics knowledge. What is the scope of the problem? Who are at risk? And what kind of jobs put at us increased risk of work-related injury and stress? Consequences of poor posture and work ergonomics. How are these strategies to be implemented to minimize or mitigate ergonomic strain and prevent work-related skeletal-muscular disorders? and what do we have as takeaway points? So, ergonomics is a scientific discipline in its own merit, which is analyzing the interactions among humans and other elements of an ecosystem. And it applies the theory, principles, data, and the methods to design in order to optimize our well-being and overall performance as well. It's crucial for the well-being and long-term health of medical professionals, and especially gynecologists and obstetricians, who spend long hours performing procedures in awkward positions. Ours is always a kind of adrenaline rush. We would rather get along to the procedure, complete it, ensuring safety, but are we safe in the process? And it designs a safe, comfortable, and productive workspace, which ours is not a 100-meter sprint. We all are on a marathon run. So are we able to sustain this kind of work-related stress and injury for a long time in our career? So we need to make sure our work ergonomics are right. So this will provide a detailed analysis of the factors influencing the work ergonomics from our perspective in the first place. So are doctors prone for this kind of problem? Are gynecologists specifically more prone for this kind of problem? A Canadian web-based survey of nearly 500 ONG practitioners demonstrated there is a twofold increase of women suffering from musculoskeletal symptoms, for nearly 3/4 of them having lower backache pain, following neck pain in about 72%, and shoulder pain, which is 66%. And wrist comes automatically because we do all our procedures, as well as forceps or vacuum delivery and ultrasound specifically. Risk factors include very busy practitioners, needless to say, volume of surgical cases, inexperience of the surgeon as well, being hasty, not taking care of their posture, and lack of awareness of ergonomic principles. Challenges in laparoscopic surgery. Now, everybody, before becoming an obstetrician and gynecologist, would like to become a laparoscopic surgeon, but we need to maintain our ergonomic postures. So it was because of the long static nature of a particular posture, operating position, prolonged surgical time, and the use of handheld operating tools, as well as mental stress and fatigue, especially with regards to the eye. There was a questionnaire-based survey with 16 questions focusing on demographics, injury data, impact of the injury, as well as general mental health. 85% of the doctors experienced pain in the last year, among which 71% attributed it to work-related injuries, with most common site was back, followed by neck and knees. This is not at all uncommon. So work-related musculoskeletal injuries among obstetricians and gynecologists, there was a cross-sectional survey done in Royal College of Australia and New Zealand. The common sites were back and laparoscopy-related injuries were mainly happening in the back as well as in the wrist. Backache in gynecologists, again, one of the most important occupational risk hazard, accounting for 72% who suffered such severe backache requiring change in work practice, 32% wherein 8% required surgery, and 2% had to take time off work. There was another particular study where work-related musculoskeletal injuries among obstetrics and gynecological trainees, this is about inexperience also, in the East Midland region of the UK, 22% aged as young as 30 to 34 about their experience with work-related orthopedic injuries. Most were injuries in the back, shoulder again, and upper limbs. 1 in 10 needed time off work, and 20 days were lost in the last 1 year due to obstetric work-related pain. So abnormal bending, prolonged shrugging, prolonged bending, and abnormal postures. These were the main reasons why such an injury was noted. So what are the risk factors? Awkward static procedures, postures mainly due to our long procedures, badly designed workstation, tools, not working tools, equipments, and working methods. Poor work organization. You do not get the adequate personnel or the trained personnel. You do manual handling yourself. You shift patients yourself. You're not raising the table level to the correct height, or you're not adjusting your stool height to the correct height, or constantly bending to do certain procedures vaginally. This will cause significant strain. Repetitive actions, which we all are subjected to. Forceful action, forcibly bending, forcibly stretching, typically ultrasound on the contralateral kidney, looking at the other side flank. Better would be ask the patient to turn this side, or when you're putting the port, tilt the patient's bed, tilt the patient's theater table, instead of reaching out and putting. Repetitive actions of abnormal stretching and forceful action cause significant strain in the oblique muscle and the paraspinal muscle, causing significant lumbago. Vibrations, people who use morcellators, constant handheld equipment, these can cause abnormal vibrations and cause problems. Environment, especially theater temperatures. We all suffered this during COVID time with our PPE. Make sure there's an ambient temperature for yourself. Lighting, do not suffer poor light. This is why we tell, even for pelvic tear repair and difficult vaginal tear repairs, please go to theater. Do not struggle with poor lighting because it significantly causes eye strain. Because of eye strain, you'll be wrinkling your forehead a lot. It will cause headache. You'll stoop down a lot, causing neck ache, backache, shoulder pain, everything. So adequate lighting, optimal exposure, good temperature, which is ambient, is important. Avoid prolonged sitting. With now, majority of the vaginal surgeons might have experienced, or with the travel involved, many people suffer from tailbone pain. That is because of prolonged sitting. Have a cushion, do not sit on hard stools, or constantly get up and walk and stretch after every 2 hours. Anything prolonged more than 2 hours sitting is significantly injurious, not only to the skeletal-muscular system, but also to the general health of ourselves. So it is important to understand not more than 2 hours prolonged sitting. So how do we set up our workplace? Maintain neutral posture. Do not shrug the shoulders. We all tend to do shrugging of the shoulders and protracting of the neck. The more we protract the neck, more tension on the spine, and with aging and osteoporosis, this can cause significant neck pain for all of us. We need to make sure our ears are in line with the shoulder when we sit. For that, we need to contract our transversus abdominis muscle. When we contract our transversus abdominal muscle, automatically you can see your spine straightens. When your spine straightens, your earlobe will be in line with the shoulder. That is the correct posture of the neck, not this. If we constantly sit 24/7 like this or operate like this, we will have severe neck strain beyond 50. Keep everything easy reach. Do not abnormally or forcefully stretch it repetitively. Work in the comfort zone. Allow movement for stretching as well as to move about. Reduce excess force. Reduce excessive motion or repetitive abnormal motion. Minimize contact stress. Reduce excessive vibration. Take breaks. This is exactly what we tell for the tissues. The more you respect the tissues, the more you start respecting yourself as well. Abnormal grip force for using any equipment. Abnormal grip force for your bipolar. Abnormal grip force for your oscillator. Everything will produce muscular fatigue and strain. Adequate lighting. Working at proper heights. This is very, very important when we tell our trainees as well. Elbow height operating table. Not too high, not too low, especially for tall people who can bend constantly to suture, or short people who do not use step stools. It is very important to use that and provide clearance as well. So correct sitting posture, the shoulder should be relaxed. It should not be shrugged. Back support should be there for all our consulting chairs as well. And the arm support for the consulting chairs. And the height of the screen should be at a certain level with a downward gaze, not higher up. You don't keep looking like this, then you will develop neck strain. It should be a downward gaze. The same thing is important for laparoscopic surgery or robotic surgery. I'll be showing you in the subsequent pictures. This is an assessment tool which is done by the occupational therapy department or even the physiotherapy department. when you report a work-related strain or stress for looking up all the work-related skeletal-muscular injuries. So they do the arm and wrist analysis, see the degree of pronation, supination. They look at the lower arm position, look at the wrist twist, any muscle soreness, posture score, as well as look at various injury patterns and give you a comprehensive score, which is called the ruler score, which is then calculated and appropriate occupational therapy is given and suggestion regarding improving work ergonomics is also advised. So this is very, very important when you suffer from such a problem. Intraoperative consideration during laparoscopic surgery. During the laparoscopic surgery, it is important that we ensure that we can move freely both sides. There is nothing low in going to the other side to put a port if you want to stretch and the patient is obese. It is about safety of the patient, but your comfort as well. When you're not comfortable, there is more hazard to the patient. It is okay to go to the other side and put the port comfortably than keep stretching and struggling. This is important for trainees to understand. Not everybody is an expert. So when you're learning, it's okay to make yourself comfortable and putting patient safety at first. Surgeon posture, again, no forward head position, no shoulder elevation, and don't put weight on one area or one limb all the time. That we tend to do, especially when you have a foot operated bipolar pedal or a monopolar energy. That will cause you to put weight on one, leave the other. That will cause irregular distribution or asymmetrical distribution of your body weight and can cause significant knee discomfort and injury. Always try and tuck up the patient's arm, especially for the laparoscopic surgery, because your movement will be restricted with the patient's arm or on the sideboards. Please tell your anesthetist to have a wide tube connecting. That is very good for all the laparoscopic surgeries and a comfortable posture for surgeons as well. And if you want to take a break, especially if you have a huge fibroid, a large uterus, or previous multiple laparotomies leading adhesiolysis, do go and do your stretches, come back and start with the surgery. Continuous maintenance of certain postures will lead to muscle lactic acid buildup and severe pain and burning in the musculoskeletal system. So you can go and stretch and come back as well. So what are the important arrangements of your equipment in theatre? The monitor screen should be placed in a neutral position. That minimizes the neck torsion, avoids eye strain and fatigue. And this depends upon the surgeon as well. If you're a tall surgeon, the same thing cannot be used by the assistant if the assistant is vertically challenged. Surgical bed, again, to the elbow height, or have a standing stool, or have a table which will go up and down. Gel foot pads, again positioned underfoot. Electrosurgical equipment device placed under the primary surgeon's foot, aligned with the target instrument and directed towards the target quadrant, eliminating the need for foot pedals. Surgical instruments, use the instruments for its intended purposes and familiarize yourself with all the available instruments. Use the shorter instruments when appropriate. Use self-retaining retractors when appropriate. Do not use your assistant to keep giving traction. One, they will become tired. There won't be adequate exposure. So use self-retaining retractors with right-angled or articulating tips, because then you will be precise in your movement. You will get the necessary effect. You will not be under extra stress, and you will not have abnormal posture-related musculoskeletal stress. The surgeon stance, as I already mentioned, should be in an ideal relaxed stature. If you keep doing upward gaze with the shoulders shrugging and the arms always in its outstretched position, that will cause immense fatigue, which is why laparoscopic surgery in complicated cases can be very tiring. So the same hold good for the robotic surgery as well. As you can see, the first one is a surgeon who's stooping into the console, whereas a surgeon who's an ergonomist will adjust the console to the particular gaze height and be comfortable. You can adjust the pedals height to yourself as well as the monitor's tilt as well as the height. It is important to adjust all this and save those ergonomic settings for yourself, so With the AI-enabled machine learning, these settings will automatically come up when you log into the system, and you don't need to keep experimenting every now and then. So these are some things which we learn as we travel through the journey from being a novice to an expert. Everybody can become an expert surgeon, but a true expert surgeon is one who is ergonomically economical and excellent. The same for the ultrasound practitioners and radiologists. Severely known wrist injuries and shoulder strain are very common skeletal-muscular disorders which are found in patients who do interventional radiological procedures as well as diagnostic ultrasound procedures. So as I mentioned earlier, as you can see, if you're standing and doing, ask the patient to tilt or move. Do not overstretch. Have the hand in a power grip position, not this way or this way, because this will cause severe carpal tunnel syndrome. It is very, very important to adapt these simple precautions when we constantly do these, because over time, our muscles and bones are also prone for wear and tear, and these will accelerate the process. Spine, no twisting, no leaning forward. Keep the head and the neck neutral. The chair position will be a slight tilt forward and avoiding the slouching position of the operator. Regarding patient ergonomics, bed positioning, we are all very notorious for bending down and doing speculum examination, pap smears, colposcopy, vaginal examination. Keep the bed at appropriate height. Do not bend too much. If it's an obese patient, make appropriate arrangements for the same. Similarly, wheelchair setup, assistive devices, and ergonomic setting, especially in the waiting rooms of your clinics as well as the rehab session. So exercise is vital for in ergonomics for promoting self well-being and also preventing work-related injuries. It is not only important that we maintain correct postures, but we also do regular strength training to avoid these musculoskeletal injuries. So regular exercises stabilizes the joints, improve the neuromuscular coordination, reduce the tension, and reduces the stiffness. It also enhances flexibility of these muscles. Back pain and carpal tunnel syndrome, definitely we know lumbago is relieved by regular exercises, especially spinal extension, and carpal tunnel syndrome, a very common problem in our sonologists, can also be relieved by exercises. And small adjustments to the workstation, and I insist all laparoscopic surgeons should do strength training exercises, especially of your upper limb, to become more efficient over time and to avoid work-related injuries. So, in conclusion, gynecological surgeons often suffer from work-related musculoskeletal disorders, and each minimally invasive surgery type, including laparoscopic, robotic, or vaginal, poses unique ergonomic risks to the surgeon. Work-related musculoskeletal disorders can affect a surgeon's career longevity. So we have to train ourselves and become expert in the surgical ergonomics. And these should be implemented without being lazy every time we practice and also train our trainees. And it should be part of the curriculum as well. And we also should incorporate training of a resident, evaluate their progress, minimize the work-related hazards so as to reduce the burnout which can be seen. So consistent rehearsal is the key. Comfortable body postures, especially shoulder down and a balanced posture. Remember, earlobe to shoulder, ergonomic movements, regular breaks, reset and stretch between the longer cases. Take a few extra moments for theater setup, which is why the WHO checklist is there, making sure everything is there in the correct place, in the correct setting. Create comfortable atmosphere among the surgical team members. Have surgical team members also trained efficiently so you can take the appropriate breaks. These measures could improve your quality of life and longevity and success as a surgeon. Thank you.
Thank you, ma'am. It was a wonderful presentation. So most of us would be experiencing a lot of backaches and all these pains at the end of the day. I think this talk will be very useful for us so that we can correct ourselves and then our quality of life will be better. Thank you.
Yes, it's a fantastic lecture, Doctor. It had been really good. And knowing about the ergonomics for surgeons, it's an eye opener for all of us, to take a little care of ourselves. It improves the quality of our surgery as well, I think. After
Absolutely.
doing 4 or 5 surgeries at a stretch, the 6th and 7th shouldn't prove a burden on us. They should be as able as we are doing on the first. So many of your tips are very helpful. I just had a doubt. What is that avoid contact stress?
Contact stress is with equipments which are constantly hot or vibrating, because morcellation of a large fibroid takes a long time. If you keep
Long
on
time.
doing this will cause significant stress, especially vibrator-induced stress.
Mhm.
So the same with contact of the screen, contact of the console, everything you need to glance out a bit, come back. That is something we all should do. It is not that you constantly dig in and keep doing the surgery. It should be, as you rightly put it, it should be safe for the patient as well.
Yeah. About that lactic acid accumulation and that stretch which reduces had been a real good point.
Typically, what happens in a busy labor ward, we all stoop and bend down to do speculum examination, quickly get on with the work, take abnormal posture to finish off the delivery, stand and do the episiotomy. That and all should be avoided. It will seem heroic at the initial outset, but over time you will become your own villain. So this is mainly for us as well.
I think we should keep these points in our labor room and theater to remind us.
Absolutely.
We keep forgetting.
All of us are guilty. All of us are guilty of doing that.
Thank you, Doctor. Thank you so much.
Thank you.
Chair, Madam is there. Can she introduce the next speaker, Dr. Jayesh Gopal?
Yeah. The next speaker, Dr. Jayesh Gopal, is an American board certified in internal medicine, endocrine, and diabetology. She's the director of Diabendo India, Chennai, and a founder trustee of the same. She's a senior consultant at Apollo Hospitals, vice president of Endocrine Society of Tamil Nadu and Pondicherry, and a EC member of API Chennai and Chennai Menopausal Society. She's the recipient of Vocational Excellent Award from she is awarded she had an oration on Sam G. Moses oration at API Chennai chapter annual conference, and she'll be talking to you about calcium and vitamin D in midlife and beyond, health or hazard. We all thought it is health, but she's probably going to address it from the other angle as well. Over to you, Dr. Jayesh Gopal.
Thank you very much, Dr. Jaya, and thanks to the organizers. It's been a pleasure. So I kept moving my position several times, Meera, in your talk. I don't know what was the right position to sit and give the talk. Thank you very much for that. Though, of course, as physicians, we don't face that much, but sitting in the same position, I think the whole day is also not a good thing for us. Yeah. Like Dr. Jaya said, this is an interesting topic. We keep talking about calcium and vitamin D, but there are some health hazards with indiscriminate or excessive use, and that's, I just want to address some of the controversies regarding that. We know all of these measures. Dr. Bharani addressed this a little bit in her talk, the measures to prevent bone loss. And we know that we need to maintain adequate calcium and vitamin D intake. So what is adequate? What is the just right dose? There is a concept that too little is bad, that we are all aware of, but there is also a concept that too much vitamin D actually is detrimental to bone health. And in the next sort of 10 minutes or so, I'll be addressing some of those studies which have given rise to this controversy. Currently, it is believed that somewhere around 25 to 30 nanogram per ml is probably adequate for most health. Whereas when you go above 45 to 50, there is a paradoxical rise in the fractures and falls. Before I address that issue, I would also just like to address this. Do we need to measure vitamin D level in all people? It's not really necessary. We can consider giving a minimal dose of vitamin D for all people without necessarily checking it. The only thing we need to be careful about is if you're going to give mega doses of vitamin D, we need to make sure that we are checking at least a calcium. So this I'm talking about, like when sometimes people are given like 6 lakh units injections once in 2 months or once in 3 months, or mega doses of vitamin D. We need to be careful that we are not precipitating hypercalcemia. In that situation, I think it's safe to check at least a calcium and a creatinine before giving long-term high-dose vitamin D. There are situations where it is important to measure vitamin D and then consider appropriate replacement. For example, people who have, say, non-traumatic fractures, hyperparathyroidism, non-traumatic or fragility fractures, of course, in osteomalacia, osteoporosis, in general, we measure vitamin D before we start therapy for osteoporosis. And certain physiological conditions, again, guidelines vary. Some guidelines say measure it in all during pregnancy and lactation, and others say only in certain situations we need to measure it. People with liver disease, renal failure, inflammatory bowel disease, cystic fibrosis, people on anticonvulsants, all of these situations which increases the risk of vitamin D deficiency, it is important to measure and replace. Of course, a brief word about, I think I've spoken about this enough. How do we make enough vitamin D naturally in our body? 10 to 30 minutes sun exposure, at least 2 to 3 times a week between 10 a.m. to say 2 to 3 p.m. with as much skin exposed as possible. If we only expose our arms, face and neck, which is what most Indian women would land up exposing, it's about 20% of our body surface area, may not be adequate, but it is better than nothing. And how do we know that our skin is made with vitamin D? Just when you start to feel the burn, it probably means that there has been enough UV exposure to start the vitamin D synthesis process in the skin. This is the recommendation as to how much of vitamin D we need. So roughly around 600 to 800 units per day is what is recommended depending on the age group, but definitely not more than 4,000. And as I shall show you, data suggests that probably not more than 2,000 IU per day on a long-term basis is necessary for bone health. And we need to keep in mind that just giving vitamin D and calcium is never sufficient to reduce the risk of a fracture or a fall. You need, in addition, regular exercise. The reason ultimately why people fall is because their muscles are weak and they fracture because the bones are weak. And for that, exercise is the most important therapeutic measure. This controversy regarding high-dose vitamin D started with this study, which was published about 15 years ago in JAMA, where they did a double-blind placebo-controlled trial of close to 2,500 women aged 70 years or older who were considered to be at high risk of fractures. And these people were given 500,000 IU of cholecalciferol. So you can imagine, it's a 60K that we give weekly once. So taking about 10 tablets of that together once a year. And then they were followed up for 3 to 5 years. And what it showed, interestingly, was that the people who were given that mega dose of vitamin D actually suffered more fractures and more falls as compared to the group that was given placebo. And you can look at the actual, and the fracture rate per 100% years was higher in the vitamin D group. And in fact, what was shown was that there was a higher risk of falls in the first 3 months after giving this mega dose. And that fell to 13% higher risk after the first 3 months. And when they measured the vitamin D levels in these people, this is the spike that you see when you got this mega dose of vitamin D, and then it fell. So this black line on top is the people who were given vitamin D, and this lighter line at the bottom is the placebo group. So you can see that they spiked, and in fact, when they spiked up, they had higher chance of falling and fracturing as compared to later on when the levels were dropping. So it is important to keep in mind that mega doses of vitamin D given all at the same time is not good for bones. Now, this is not the only study to show this. There was another study which was done. This was among men and women. and close to 10,000 people. And in this, similarly, people were given 300,000 IU of vitamin D, IM. They were given this every autumn over 3 years. And in this group also, there was either no reduced risk or a slightly higher risk of hip fracture. So the risk of hip fracture was about 1.5 times higher, and the risk of a wrist fracture was also about 20% higher, and it did not reduce the risk of falls. Again, there have been several studies to show that mega doses of vitamin D given, say once or twice a year, does not seem to help, and in fact may be detrimental to and increase the risk of fractures. However, several other studies, many studies, I'm not going through all of them obviously, but several other studies have shown that daily, what would be considered a relatively low dose, but which is the proper maintenance dose, has consistently shown benefits in improving bone health. So for example, a daily supplement of 1000 mg of calcium and 400 IU of vitamin D showed a 16% reduction in fracture rate. Similarly, in another community, in another study among community living people, calcium 500 mg per day and 700 IU of vitamin D per day reduced bone loss and reduced the incidence of non-vertebral fractures. And one other thing which was interesting was this was a meta-analysis comparing the effects of combined vitamin D and calcium. And what it showed was that the type of vitamin D that you give also depends on whether people are where the people are living. Is it people who are living in nursing homes, institutionalized people, or is it community dwelling people, or is it community dwellers with a history of a fracture? So in these three groups, there is a difference. So people who are institutionalized may actually benefit from getting a vitamin D supplement on a regular basis. It may not be that helpful in people who are living out in the community, maybe because people living out in the community are generally more active as compared to people who live in, say, a nursing home, who would probably tend to be less active. So people who are less active, bed-bound, not very mobile, will benefit more from a low-dose daily vitamin D supplement. So the current recommendation is maybe give around 400 to 800 IU per day, certainly not more than 2000 IU per day. Now, why might large doses of vitamin D actually adversely affect bone health? We are all taught always that vitamin D is good for bones, vitamin D is good for bones. Why is it that giving a mega dose of vitamin D is actually proving detrimental to bone health? There are several postulated theories, nobody is very sure, but one reason is that they feel that that spike in that 125 levels that occur, so immediately after giving a mega dose, there is a spike in your the active form of vitamin D, which is your 125 dihydroxy vitamin D3, that can actually enhance the osteoclastogenesis. So the osteoclast cells get activated more than the osteoblast cells, so that there is more breakdown as compared to bone formation. Also, this effect of high vitamin D supplementation seems to be more marked in females rather than males. For some reason, women respond differently to mega doses of vitamin D as compared to men. We respond with a higher risk of fracture tendency as compared to men. And it also seems to be different depending upon the differing sites. For example, changes with high dose vitamin D, 4000 IU per day, tend to be seen more at the radius and in the ulna and the wrist, but not at the hip and spine. So these are all things we need to keep in mind, that we are not fully sure why mega doses of vitamin D given in a blast, once or twice a year is probably not good for the bone health in the long term. I think when we are replacing vitamin D, what we normally do, which is the 60,000 IU weekly ones for 8 weeks, is okay. But long term, it is always better to give lower doses gently. So 1000 IU, 2000 IU per day is something I think I would definitely recommend, rather than giving a mega dose periodically. Now, what about the calcium? Again, the calcium intake recommendations vary depending on the age. So the recommended allowance for most adults is somewhere around 1000 to 1200 milligrams per day, but not more than 2000 to 3000 milligram per day. So this is the average recommendation of calcium intake. Types of calcium does make a difference. Calcium carbonate ideally should be taken with food for maximal absorption. Calcium citrate is slightly better absorbed, can be taken on empty stomach also, but both calcium citrate and calcium carbonate actually it's better to take it with food or after food to reduce the oxalate absorption, to reduce the chance of calcium and oxalate levels building up and thereby increasing the tendency towards formation of kidney stones. So better to give calcium supplements with food. Second, very important thing is to give the calcium, not to give more than 500 mg of calcium at a time. It's better to split and give it, because when you give a larger dose, the percentage of the calcium absorption anyway comes down and you're not going to absorb. So at a time, it's better to give 500 mg of calcium. And also there is more, some people don't tolerate calcium levels very well. Calcium preparations which also contain magnesium can counteract constipation. So this is just a simple thing. Most of the tablets we give, generally usual supplements we give, will have calcium, vitamin D and magnesium in it. So it's okay to use the magnesium component. You can use that to reduce the side effects, the gastric side effects to the calcium. Always food sources are preferable for calcium intake compared to supplements, compared to calcium tablets. And another thing to keep in mind is how much of actual elemental calcium is present in the type of calcium we're giving. So calcium carbonate is 40% elemental calcium. So if we take a 500 mg tablet, only about 200 mg of that is actual elemental calcium. So that's important to keep in mind when we're trying to calculate. So if you give 2 500 mg tablets per day, you're probably providing 400 mg of elemental calcium per day. And they will still need to take, to come up to the 1000 mg, they will still need to take, say, 1 glass of milk and a bowl of curd along with this 2 tablets of calcium. Calcium citrate, which is the other one that we commonly use, actually contains even less. It's only about 20% elemental calcium. So it's important to immediately calculate actual amount of calcium, how much they will be getting, and not just look at the total calcium that they have. So the best sources of calcium are always dairy. Milk and yogurt for us is a very, very good source. Apart from that, cheese and greens are also a good source, but you can see the difference. So this contains about, say, 100 mg per cup of all the kira and the spinach and all that we would eat, whereas this contains about 300 to 400. Yogurt tends to have more calcium per volume compared to milk. If you're trying to get in 1000 mg of calcium per day, you need to have, and if you're only going to turn to milk as the source, you need to have at least 3.5 glasses of milk, provided the cows are not calcium deficient. If you're lactose intolerant and you cannot have, you can go for lactose-free supplements. Otherwise, you can go for vegan sources. These are all some of the vegan calcium sources. So some of the higher ones are things like tofu, flax seeds, sesame seeds. We use it quite a bit. So even though it does not contain much, the fact that we'll be using it regularly gives us enough calcium. Almonds are a good source. Figs are a good source. Raisins are a good source. All the greens are a decent source of calcium. Vendaka, okra is a good source of calcium. So these are all the vegetarian sources of calcium. So it is not to say that just because you're vegan, you need to have calcium supplements, provided you have a balanced diet. And overall, you're getting at least about 800 to 1000 mg of calcium per day. Your bones should be fine. Now, there is equally a controversy about calcium intake. This probably started, this controversy has been going on for some time, but one of the earliest studies that reported this controversy with calcium was the Women's Health Initiative, which showed that postmenopausal women who were supplemented with calcium and vitamin D had a higher risk of kidney stones. So this is where this controversy started appearing. And this study, which was published in the BMJ in 2013, it was a community-based prospective longitudinal cohort study. 61,000 women followed up for nearly 20 years. They estimated their calcium intake by a food recall, which is not a very accurate method, but still a decent method. So the food recall questionnaire, how much food do you take? How much of calcium supplements do you take? And what it showed was that people who took in dietary calcium intake above 1,400 mg per day, the hazard ratio for all-cause mortality was 2.5 times higher, with a fairly significant confidence interval. So, this was a significant. It was there is some truth to the fact that if you take too much calcium, it's probably detrimental to your health. Several studies came out about 10, 12 years back. There was a series of about 3 studies which are all published in the BMJ, all of which showed that meta-analysis of previous studies showed that calcium supplementation increased risk of a heart attack and cardiovascular events. So this was a study looking at 16,000 women not taking calcium supplements. And then when the WHI began, they put on calcium and vitamin D, and they seemed to have about a 16% higher chance of clinical MI or need for revascularization. Similarly, the analysis of data from other trials looking at about 28,000 patients again showed that there is about a 15% higher risk of cardiovascular events in the group that was given calcium with or without vitamin D. So whether it was the calcium or the vitamin D, this study addressed that. So it looked like the group that was given calcium alone, higher risk of MI and stroke. Similar data, 9,000 people followed for 10 years, postmenopausal women taking 500 to 1,000 mg of supplemental calcium had a survival advantage. Now, this is a bit of a controversial issue, but certainly higher than 1,000 mg or 1,400 mg per day certainly is associated with an increased risk of mortality, heart attack, and stroke. Similarly, why may excess calcium increase CV risk and mortality? So the transient hypercalcemia may trigger the coagulation cascade, triggering thrombotic events. It may cause increased vascular smooth muscle contraction, increasing the blood pressure. Increased vascular deposition of calcium may cause, accelerated sort of thickening of the blood vessels and arteriosclerosis. So, and it may cause direct plaque calcification. These are all postulated theories. Again, nobody really knows. But suffice it to say that both mega doses of vitamin D and very high daily doses of calcium are probably not good for our health in the long term. So to summarize, adequate vitamin D levels are necessary for strong bones and to reduce risk of falls and fractures. Probably 30 to 50 nanogram per ml of vitamin D levels are adequate, maybe closer to 30 to 40, not near the upper limit of normal. Certainly, daily supplements not exceeding 1,000 to 2,000 IU per day may be preferable to large dose yearly or once in 6 months supplements. Calcium best obtained from food sources aim to take in about 1,000 mg per day. If you feel that the person is not taking in adequate calcium from the diet, add in maybe a supplemental calcium, keeping in mind that if you're giving calcium carbonate, you need to give 2 tablets of a 500 mg to get up to 400 mg of elemental calcium per day. Certainly do not exceed 1,400 mg per day calcium supplements, because this has been shown to increase the risk of cardiovascular disease and all-cause mortality. So I'm going to stop here, and I'm sure we'll have a very spirited discussion around this topic. Thank you again.
Thank you very much, Doctor. It has been very good. Very good. All topics are good. It's very good. Regarding the over supplementation of vitamin D, it has to be repeatedly told to, the practitioners, even all of us. All of us just going on prescribing vitamin D and calcium for every bone pains, for every skeletal pains that the patient comes and tells us. I think that's not the answer. You have to investigate, find out, and I think that should make us write appropriate doses. Very correct. It's been really good.
Thank you.
Jayashree, what about the 60,000 IU which we give for insufficient patients?
I know. So after going through the literature, now I've decided I'm going to give, I think the replacement is okay. So this we are talking about, the people in whom we are doing like
prophylactic.
Prophylactic. I think for these people, it's better to give 1,000 to 2,000 IU per day. Rather than even, at least I decided I wasn't going to do any more 60,000 per month also. I used to do that earlier. I've decided to change my practice and give 1,000 to 2,000 IU per day.
Per day. Even that increased extra calcium every time whenever a woman of 40 or menopausal, perimenopausal comes, we even on telephones will tell them to take calcium or vitamin D. I think it's wrong because it increases all-cause mortality and
yeah, I think calcium in general, I think the usage has come down over the years. I think what is important is to try and get the calcium from diet as much as possible and make
Absolutely.
sure they have enough vitamin D to be able to absorb the calcium.
So pill is not the panacea for all problems.
Absolutely right.
Cannot pop a pill for any.
Absolutely right.
I know. Whenever there is anyone who is complaining of any pain or bone pains and that she is 40, menopausal, the first thing that comes to everyone's tongue is take some calcium or vitamin D. I think it should be a little with caution we should give.
Yeah,
Only
this
if there is
is why
deficiency.
this topic was chosen for.
Fantastic.
Yes.
Really
Yes.
good topics.
And the other
What about
caution is pregnant
what-
women also, because fat soluble vitamins are not supposed to be taken in the first trimester because they can cause toxicity. When we prescribe 60,000, they continue to take it. It's not correct. So we have to insist, as Dr. Jayashree rightly put it, I think we should stay away from that 60,000 one.
You won't get sponsors.
If
You won't
not-
get sponsors.
Is there any way where we can check vitamin D and calcium, madam? Do we
what
have to
about-
check the levels? No, whether we are overshooting or we are giving more calcium, is there any way where we can check their calcium and vitamin D levels for patients and stop giving like that?
Yeah, I mean, in general, yes. I mean, the vitamin D level is, like I said, around 30 to 40 nanogram per ml is what is recommended. It's a good idea to also check the calcium because, you know, some people may have some undetected hyperparathyroidism, primary hyperparathyroidism, and sometimes giving the mega doses of calcium causes the calcium level to go up. Both calcium and vitamin D need to be taken on a fairly regular basis. At least there's minimal doses on a regular basis.
What
I would
about
say
calcium in milk, coffee and tea and all? With milk, they say that doesn't count for your calcium.
it doesn't
is it?
count because caffeine can cause, like if you're taking 4 cups of coffee a day, probably the amount of caffeine is going to counteract the effect of the calcium because caffeine has a detrimental effect on the bone.
Jayashree, when you mean a mega dose, what do you really mean? You kept using the word, no, mega dose.
Mega dose is what I said in the study, which is like 600,000 IU. In our country, we'll probably be giving it as an injection, no? When we give, like sometimes for children with osteomalacia, we give these 6 lakh units IM. So that's what the study did. They just gave one, you know, that oil-based injection. But having said that, even when they looked at studies where they were giving 4,000 IU per day of vitamin D, it did not show any benefit on the bones.
Jayashree, there were a couple of studies, wherein you can give a little high dose of calcium in pregnant women in order to reduce the incidence of pregnancy-induced hypertension. There were studies, what is your opinion on that? Because there were many studies. The PIH is one, which is really a botheration for all of us. And they said when you give a high dose of calcium for these women, you can actually prevent pregnancy-induced hypertension. So we get conflicting reports, so...
No, but today my topic was only about bone health. It was only in menopause and beyond. I'm only talking about an older age group in the women who are just coming in for preservation of bone health. In that age group, we should be careful about not overdosing with calcium or vitamin D.
No, that point is well taken, Jayashree, that we understand you shouldn't give. But then I'm generally asking, because in pregnancy-induced hypertension, they say if you give high dose of calcium and vitamin D, to a certain extent, you can actually, prevent studies.
High dose, they mean
But
is 1,000 milligrams.
the clause is in
1,000.
calcium deficient patient, no? Not in all patients, no?
But even the
The
high
study
dose
said that in
only
calcium
1,000 milligrams.
deficient patients or deficit areas, you can prescribe higher dose of calcium. It's not for all patients, no? That's what I thought. I don't know.
No, the recommendation is there. That is in people who do not take adequate calcium in diet and who are prone for PIH, whom we think a high dose of calcium can be given. That is a recommendation by
Madam, that too, they say only 1 gram, madam, 1000
yeah,
milligram body.
maximum of 1 gram. That is 1 gram of calcium is permitted. That is for short periods. They talk about calcium only.
And sometimes even addition of magnesium also is beneficial for prevention of PIH or pregnancy-induced hypertension in pregnancies. That is what used to be the fashion, along with calcium with magnesium, which will prevent PIH in future. It was a prophylactic advocacy at that time.
Even now, I mean, that is studies have clearly proved that in people who are deficient in calcium and who are for the hypertensive disorders of pregnancy, and we have to improve the calcium in the diet. If it is not possible, then 1 gram. That is what. So we are supposed to sit and talk to them about all sources, and then it can be done. That is the recommended thing.
Madam, do we have the quiz session now, madam?
Yeah, quiz now. Yeah, let us go on to the quiz.
Can everybody switch on the video so that we can take a photo? I think everybody, all faculty seem to be here. Bharani, Dr. Rajalakshmi, and yes, Dr. Anuradha ma'am. Yes. Sahiti, can you take a picture?
Yes, ma'am.
Yeah. Smile, please.
Raji?
Raji?
Yes, ma'am.
Yeah, switch on your video, da.
Divya?
Divya? We're just trying to take a photo for 1 minute. Yes.
Done, ma'am.
Yes. Thank you. Can you post the questions?
Yes,
of course,
ma'am.
they will not be open to the faculty. Open to the delegates who have joined.
Behind time.
Yeah. Shall I launch first question, ma'am?
Yes.
Yeah, ma'am.
So
Keep
first
timing. Keep timing.
Yeah. 30 seconds only, no, ma'am?
Yes.
Yeah.
Okay, ma'am.
Sakiti. So this will be the one. Which hormone plays a key role in regulating calcium levels by increasing calcium absorption in the intestines? Insulin, parathyroid hormone, thyroxine, cortisol.
Five more seconds. Timer. Second question.
Which form of vitamin D is produced in the skin upon exposure to sunlight? Ergocalciferol, polycalciferol, calcitriol, and calcidiol.
Five more seconds. Timer. Third question.
What is the primary active form of vitamin D that aids in the calcium absorption in the intestine? 25-hydroxy vitamin D, 1,25-dihydroxy vitamin D, that is calcitriol, vitamin D2, vitamin D3.
Five more seconds. Timer. Fourth question.
68-year-old woman visits a primary care physician for annual checkup. She mentions that her mother had multiple fractures in her later years. She's concerned about her own bone health. She's not experienced any fracture herself, but recently noticed a slight decrease in her height. Which of the following would be the most appropriate step for assessing her risk for osteoporosis now? DEXA, or advise her to take calcium supplements only, or refer her for physiotherapy, or schedule her for a spinal X-ray.
5 more seconds. Timer. Fifth question.
72-year-old man with history of osteoporosis presents to emergency department after a fall. So actually, although we are only menopause society, we wanted to bring this into imaging confirms a hip fracture. Medical history includes high blood pressure and type 2 diabetes. Currently takes calcium and vitamin D supplements and antihypertensive medication. Which of the following treatment would be most appropriate to initiate in addition to his current regime to reduce his fracture risk? Increase in calcium intake, add on bisphosphonate medication, start on anti-inflammatory drug, begin the physical therapy exclusively, exercise, strength training, all these things.
Five more seconds. Timer.
Thank you, Sakiti. Raji, please take over. We will go on to the next.
There were 5 more questions, ma'am.
Enough, ma. Enough.
Okay, ma'am. Sure.
5 questions. That's it.
We shall move to our next session, a most awaited session on Ask the Experts. I request our chairperson, Dr. Kalevani Madam, to chair the session. Ma'am is the Director, IOG, Government Women and Children Hospital, Egmore. She's PAF Director, KGH, and Superintendent of RSRM lying in hospital. She is UG and PG teacher for the past 26 years. She has presented various papers in both national and international journals. She has conducted workshops on basic obstetric skills and emergency obstetrics in various forums. She has received BEF Doctor Award by Tamil Nadu Dr. MGR Medical University in the year 2018. She is the Chairman Board of Studies for postgraduates in OPG, Tamil Nadu Dr. MGR Medical University. She is member of OXY, TAPISAR, CMS, SOVSI, and DIPSI. I request ma'am to introduce our moderator and speaker for the session. Over to you, ma'am.
Thank you, madam. Thank you for your kind introduction. At the outset, I'd like to thank the organizers for giving me this opportunity. I think we have heard from the previous speakers about bone health, its prevention, screening, and management. And it's high time we can ask our experts regarding this. And to moderate the session, I'd like to invite our vibrant treasurer of Chennai Menopause Society, Dr. Dhanalakshmi Madam, to take over the proceedings. And I'd like her to introduce her experts. Over to you, ma'am.
Thanks, madam. Nice to introduce JG ma'am, and she's a founder president of Chennai Menopause Society, formerly called as Chennai Menopause Chapter, and she is a senior consultant at Apollo Specialty Hospital and Mangai Women's Health Exclusive, and also at MGM Healthcare. She's a gold medal in clinical medicine and MBBS, president of OXY in 2008, and chairperson of the AICC RCOG South Zone between 2008 and 15. Founder, secretary, and president of Chennai Menopause Society, and president ATN RCOG. And she was the president of SOVSI Tamil Nadu chapter till 2024 before Madam took over, and this Dr. Award from Dr. India Medical University. Madam is NJ Madam. She's senior consultant in obstetrician, gynecologist, and very popular one at Apollo First Med and Cradle Hospitals. Merit scholarship for MBBS, University first rank in the MD exams. This Doctor Award from India University in 2010. She was a president in OXY between 2015 to 2016. She was an active member of ATN RCOG, OXY, IAG, and IMS. Field of interest, high risk pregnancy, endoscopic surgery, and pension. Nice to welcome alumni from my own institute, Dr. Sendil Kavalsekara, Senior Consultant Orthopedic Surgeon from Apollo Hospitals. And he is experienced in knee fellowship. She's been at London Bridge Hospitals in joint replacement surgery and has performed over 1,000 joint replacement surgeries of the hip and knee. Expert in the management of trauma, spinal injuries, and sports injuries of the knee and shoulder, requiring ligament reconstructions. Practices regenerative medicine for prevention of arthritis, including stem cell procedures. Welcome you, doctor. Next. Our own Jay Srigopal, another GAG, Director of Diabetic Endo India, Chennai. And we'll move on to the panel because we have already lost about 10 minutes. It's going to be only shooting questions at the experts, and the experts are going to answer. And Sahiti, can you share my screen?
Just a second, ma'am.
Sure. All right, can I share from my end?
Yes, ma'am.
Is it visible?
Yes, madam. Your name has come. Yes.
Visible now?
Yes, madam,
Is it
visible.
Now that we introduce our panel of experts, we'll just move on to the first set of questions directed towards Dr. Jayashree Gujarat ma'am. And madam, which are the gynec cancers you think would affect the bone health adversely, either by themselves or the treatment instituted to cure them?
See, most of the time it's not the cancer per se which affects the bone health, though it can indirectly do it. The association has been found between endometrial cancer, a major drop in the bone density, especially after the treatment, as in either oophorectomy or any kind of adjuvant treatment that may be given. With regard to cervical and ovarian cancer, statistically, it's been shown that somehow people who are affected by these cancers or diagnosed to have these cancers actually start off with a low bone density. Other than that, it's always mostly treatment related.
So, what measures would you be taking during gynec cancer treatment to optimize bone health, ma'am?
I think to begin with, extremely important to keep in mind that there is life for this woman after her cancer treatment, which means we have to ensure that she's in good health. And one of the major aspects that we need to think about is the fact that she may be prone for, falls, etc. later on. So a baseline BMD is something that I would always recommend. And any treatment that would affect the bone health, for example, oophorectomy, or when she goes in for prolonged chemotherapy, where again the ovaries are going for a menopausal state. Some of these cancers, you give them LHRH analogs, etc. So these are conditions where we need to keep in mind the possibility of bone loss and ensure during the treatment of the cancer itself that they get adequate, vitamin D supplementation. And where the score is very poor, if necessary, bisphosphonates also needed to be added on. Breast cancer patients, again, who are on letrozole, is something that we need to keep in mind.
So, breast cancer treatment and adjuvant therapy, what we use post cancer surgeries, how does it affect bone health, ma'am?
So these are actually the SERMs, etc. Then when we are using them long term, we need to keep it in mind. At the risk of osteoporosis and osteopenia is definitely much higher, and the treatment of the breast cancer itself again increases the fracture risk. So though it's such a common diagnosis, and we are often thinking of survivors after breast cancer, it is important to protect the bone health throughout the treatment and ensure that after they complete also, we do a BMD, find out what their
BMD is and treat accordingly.
Yeah,
So
when I was going
maintenance
through
therapy is very
literature,
important.
yes, ma'am. When I was going through the literature to find the answer for this question, which was given, all questions are given by Meera, thanks to her. Breast cancer will weaken bones by causing inflammation. Is that proven theory, ma'am? This was in
It's
that.
a postulation, but there is no definite proof and nothing that needs to be, no action that needs to be actually taken specifically for it.
So how to ensure optimal bone health in cancer survivors? Already you are told part of it.
Yeah, I think to begin right in the beginning itself, we need to be thinking about it, which sometimes I find is lacking when they are doing the onco treatment. They don't think of these women as women who would survive after the treatment. So from the beginning, keeping that in mind, ensuring that they take adequate vitamin D, activity, etc., lifestyle, all this has to be emphasized. And yes, as you have mentioned, smoking alcohol is very, very important. We need to keep that also in mind. Some of these cancers can also go in for metastasis. For example, the uterine sarcomas, etc., vulvar carcinoma, these can throw up bone mets more easily. So in these situations, we need to look at the bone, need to make sure that enough investigation and evaluation is done for the bone health.
And your final verdict, ma'am. Do we do prophylactic oophorectomy?
In a woman who is not at a family history risk, etc., I normally use 50 as a cutoff for my own patients when counseling them, because I think somewhere we have to draw a line. It's all very well to say that yes, ovaries should not be removed, ovaries should be left out, but all of us have seen not just simple cysts, but even carcinoma developing in ovaries which have been left behind. So I use 50 as a cutoff. And beyond that, just for the sake of the testosterone that would come from it, I think it's not justified in leaving the ovaries behind.
Thank you so much, Manav, for answering our queries on behalf of the delegates who have joined us. And this are the expert opinions from our gynec oncologist. And we will move on to the next expert, Dr. Nirmala Jaishankar, very busy clinician. And we will pose this question to her. Madam, what do you think about premature menopause and HRT? Do you think is it necessary to think about HRT at all for a patient who attains menopause say, at around 38, 39 years?
Yeah. So we define premature menopause as someone when menopause happens less than 40 years of age. But I really want to bring up one thing, Dana. Nowadays, when women have endometriotic cyst, they undergo sometimes multiple lap surgeries. So in the last a month, I had two young women, 30 and 34. They had endometriotic cyst operated once, and then they tried for fertility. Again, they got operated. So do not forget the surgical menopause. The surgical kind of a depletion in the ovarian follicle is also happening. And also keep in mind when for some connective tissue disorders, if they are given things like cyclophosphamide, say for SLE patients, they can also go in for a premature menopause, and definitely a big yes. You should definitely give them hormone replacement therapy if there are no medical contraindications for giving such treatment.
Madam, would you prescribe COC combined contraceptive pills or HRT, which is costlier? Say, for
What
example, a
normally
combination.
Sorry, what is it, Dana?
Madam, do we prescribe contraceptive pills as a form of hormone replacement therapy, or would you go in for a combination of 17-beta estradiol or conjugated econ estradiol with the dydrogesterone or a micronized progesterone?
I think this is in young patient, we can give a combined contraceptive pill. Maybe the estrogen that you choose will depend. Supposing she is a very young patient, you might choose 30. And if she is going to be like 42, 43, you might choose an estrogen containing 20. You continue this till her natural age of menopause. And after that, you need to have a one-to-one discussion, because many patients, they do not want to take the pill after the natural age of menopause because they think that they have taken these medication for a longer period of time. So that decision has to be individually based. And supposing you feel that their cycle control is good, and if you want to switch over to hormone replacement containing either 17 beta estradiol or estradiol valerate with the lipid-friendly progesterone like dydrogesterone, you can do that also after 45. Generally, you can start with a low-dose combined contraceptive pill.
Madam, we must be meeting a lot of fertility patients coming with fertility issues. Do you think the treatment that you offer can adversely affect the bone health? Because you are going to use aromatase inhibitors to a large extent.
Dana, a bit more
Dana,
loud.
madam.
Where not here. Yeah. Bit more loud.
Volume increase பண்ணுங்க madam. Dana ma'am.
Okay.
Generally, infertility treatments are used for a short period of time, and we don't use it for a longer period. So by and large, if you use either letrozole or GnRH analog for a short period of time, I don't think it should have any impact on the bone health. Only, when you're going to use it for a longer period of time. Say for adenomyosis, nowadays they are suggesting that you can use anastrozole 1 milligram for a longer period of time. And there are also people who are advocating letrozole 2.5 milligram along with calcium and vitamin D for endometriosis. So if you're going to be using for a longer period of time, then I think you should be aware of the effect on the bone health, because we know that letrozole is an aromatase inhibitor and it reduces the estrogen level. But if you're using for a very short period for infertility treatment, I don't think it should affect or it should have a major impact on the bone health.
Thank you, madam. And what about contraception and bone health?
Okay, contraception, combined oral contraceptive pill, we know that there is no effect on the bone health. Supposing you put a patient on Depo-Provera or progestogen only pill, then maybe. But in this patient, you can actually supplement calcium and vitamin D if you think that they need the contraception. So you can individualize and use accordingly.
The latest WHO position statement, ma'am, that there should not be any restriction for the use of DMP or COC between women between 18 to 45 years.
Yeah,
because
they
I
are,
was also
they are
had this
younger
apprehension.
patients. Yes.
Apprehension whether DMP in the long run would cause osteoporosis, amenorrhea, and bone health.
Amenorrhea, we know about anorexia. When there is less caloric intake, less intake, then it can definitely affect the bone health. Yeah, I think anorexia nervosa or any other condition where you have less of estrogen and less of caloric intake, less of, their weight is less, then it can definitely impact the bone health.
So you're going to address them. Suppose you a mother brings her daughter.
They need a lot more psychological counseling, no, Dana, rather than just calcium and vitamin D.
Yes.
So we really need to talk to them as to why athletes, at least they are exercising more. No, I'm not worried about them, but I'm really worried about the girls with anorexia nervosa, where they have, a body image problem, they have a psychological overlay. They are the ones whom I'm worried about, because athletes will take good protein and they will exercise. Maybe not so much for an athlete, but for a patient with a psychological issue like anorexia nervosa.
Thank you, ma'am. And we will have the next set of questions directed towards Dr. Sendil Kamala Secret.
Dana, little bit louder, Dana.
Yes, madam. That's why I wanted Sahiti to share the screen, because I know my volume will go down. Am I audible now? Am I audible?
Yes, now it's okay, ma'am.
Yes. Sir, can you tell us which are the patients who will need a bone mineral density assessment?
I think, am I audible?
Yes, you are audible.
Yes, sir.
Yeah. Generally, people, I think, in women above the age of 50 or 60 years of age, who have, or women who have actually kind of attained menopause early and who are not on any calcium or vitamin D supplements, I think they would be fall into the category of getting a bone mineral density test, But ideally, I would say the elderly women above the age of 60 would be better to have the test done. And obviously, if you have a patient who's got medical problems, like who's on rheumatoid and who's been on long term of steroids and other things, they also will fall into the category of getting a bone mineral density test done.
And as Madam rightly pointed out, before initiating any treatment, cancer treatment, I think it's better to have a baseline BMD done, and then so that we'll have an idea of whether this cancer treatment has any, adversely affected the bone mineral density in the later half of our life. And what about this weight loss medications and bone health? Nowadays, people are conscious about their health, and then they want to somehow reduce medications at a short course of time. And what do you think will this medications have on their bone health?
I think weight loss medications, as long as if the patients are, or if the people are actually into physical fitness regimen, then we advise an adequate amount of exercise to keep yourself fit. But however, I think if you have a rapid weight loss and you don't take adequate supplements, maybe calcium, vitamin D, or even any other supplements to or proteins to maintain the homeostasis of your bones, then I think your bones get weaker, and then the chances of fractures increase. Yes.
So, which means that you are supposed to undergo this weight loss program under a trainer or under supervision.
Under supervision, yes. Yeah.
Okay. Because many of the patients who come to us go through Google and then they do everything on their own. So, so that point should be well taken. And what about calcium prophylaxis? We had enough evidence-based talk from Dr. Jaisha Gopal. So, what is your take, sir? Calcium prophylaxis.
No, calcium. We generally prescribe calcium for anybody who's having bone pains and who have actually kind of a lab result which shows them having a deficiency of calcium. So, and also we prescribe it for people who are having have fragility fractures. So, if you have a patient with a spinal problem who's got back pain and he's of the elderly age group, then actually for them we put them on some calcium supplements. So, calcium is, I think, required. I think.
And what about vitamin D, sir?
Vitamin D, obviously, for the absorption of calcium, we need to. So, as previous speakers have mentioned about the absorption of calcium when we have vitamin D intake, is actually you need to get that elemental calcium. So that elemental calcium, you need to reach that level so that you don't become calcium deficient.
And what are the metabolic profiles to be evaluated before supplementing this vitamin D or calcium? Do you think everything has to be evaluated, or you want to go in for select investigations?
No, generally, when we are supplementing a person for osteopenia or osteoporosis, we do the test. We check the renal profile. We make sure that the urea creatinine is okay. We check for the PTH hormone. We check for the bone resorption. So we check for alkaline phosphatase. And apart from that, these are the main things which we look for before we start supplementing for any treatment for osteopenia or osteoporosis. Yeah. So metabolic diseases, obviously, we have to look into that. So hyperparathyroidism, and also sometimes some people with thyroid disorders also we look into, so that we can make sure that they are adequately supplemented for the calcium.
So calcium, vitamin D, and alkaline phosphatase, and renal profile and thyroid profile. Is that okay?
Parathyroid hormone, PTH.
So, usually orthopedicians are known for giving alendronate or bisphosphonates in the long run to unlike gynecologists who hesitate in giving these drugs to the patients. And what do you mean when you give drug holiday regimes for this kind of patients who are receiving this bisphosphonates for a longer period of time?
Bisphosphonates, I think, should be given. I think when you have patient who is actually kind of bisphosphonate probably for osteoporosis. And I think for people who have had a history of fragility fracture somewhere. So, a drug holiday, I think it's, I'm not very clear about the drug holiday theme. Yeah.
That is what is mentioned when you give.
Dana, a bit more louder. Probably Jayesh take this up. Jayashree Gopal can take this up. This drug holiday.
Can I just answer that, Dr. Danas? So drug holiday is only for bisphosphonates. Currently, we have three main medications for osteoporosis. That is recombinant PTH, which is an anabolic agent. We have the bisphosphonates, which are preventing the breakdown, and we have denosumab, which also prevents breakdown. The first one, the anabolic agent, recombinant PTH, it is recommended that it be used anywhere from 1 to 2 years as a daily injection. The bisphosphonates, whether we are giving alendronate or zoledronate or ibandronate, in general, it's recommended that we use it for 4 to 5 years. Do a DEXA scan about 1 to 2 years after you start to make sure people are responding appropriately. At the end of 5 years, that is when we're supposed to give a drug holiday. That's only for bisphosphonates. The reason for a drug holiday is with the continued use of bisphosphonates, it leads to something called adynamic bone. It will freeze the bone. It prevents any further turnover in the bone. So you stop it and see whether the bone density remains stable. If you stop it, you repeat a bone density after a year. Now, this is only recommended for people who have a good response and the bone density is improved. If they have had several fragility fractures, if their bone density is low, it is not recommended. Drug holiday is not recommended. The third medication, the denosumab, should never be stopped. There is no concept of drug holiday for them because once you stop it, there is a rebound increase, particularly in vertebral fractures. So that is one, in a way, if you think about it, disadvantage of using denosumab because you should never stop it. So the first one, the anabolic is for 2 years max, the recombinant PTH. The second, bisphosphonates, at the end of 4 to 5 years, you can give a drug holiday in certain situations. Denosumab should never be offered a drug holiday.
Thank you so much, Jayashree. And again. And doctor, how do you decide which medications for whom? You have a variety of medications available these days for treating osteopenia and osteoporosis.
Yes, I think the newer medications like denosumab and the recombinant PTH, teriparatide. Generally, if you have a patient with fragility fractures and who is very osteoporotic, then we go for a combination of giving denosumab and PTH. Obviously, PTH, we can't give it for more than 2 years. However, for the people who are osteopenic and who have their blood levels and all within normal limits, we can give only denosumab. So that, but obviously, I think we can give it for a period of time to make sure that, and repeat their bone mineral density to make sure that they are up to scratch.
Jayashree, do you want to add anything to this?
Yeah, I mean, pretty much the same thing. If there is severe osteoporosis, then you put them on an anabolic agent followed by a anti sort of catabolic agent. Whereas if it is regular osteoporosis, the recommendation says, and they've not yet had a fragility fracture, you've only decided on therapy because of the FRAC scores and all that, you can either start with bisphosphonates or you can start with denosumab. Either one is okay. Like I said, the differences are only if people are not wanting. So there is more side effects with the bisphosphonates. That is how we practically choose. So the first dose of, say, zoledronic acid, alendronate causes more acidity problems. Zoledronic acid tends to cause more, like a flu-like reaction, the first 2 doses. Denosumab is very, very well tolerated. So there's just a little bit of difference between the 3 as to decide which one is best. And denosumab is a subcutaneous injection. You can take it at home. Zoledronic acid, you do have to go into the hospital because it's intravenous. So, but there is no difference. The guidelines say we can choose either denosumab or this thing and reserve the anabolic agents for very severe osteoporosis or multiple fragility fractures. So multiple vertebral fractures, in that type of situation, better to start with an anabolic.
Right. Thank you, Jayashree. And now the next set of questions, so the last set of questions goes to Dr. Jayashree. And bone and joint, which is worse in women, which was affected more in women, I think.
I think both are affected equally badly.
I just wanted to where shade worse.
Sorry?
A shade worse. One shade. Which is
bone or joint.
Bone or joint.
We see equal number of women with, I would say I'd probably see more women with arthritic complaints. Bone, they don't complain with it, but knee arthritis, hip arthritis is so common.
So common.
Particularly osteoarthritis. So
you would vote for joint pain. Okay. Does running affect joints? Because we feel hesitant when unless you are a regular marathon runner, we don't advocate running or jogging for our elderly patients.
I
does it affect joints?
I don't think it affects the joints. It's my understanding that it gets affected if you run for long periods on the treadmill. If you pound away and you have arthritis to begin with, and you're not putting your pressure in a proper way. But I think certainly walking outside or jogging outside, provided you're wearing proper shoes and the surface is okay, I don't think it's bad for the joints.
So what type of exercise would you advise for women with knee pain?
Quadriceps.
So, yeah, thank you. I think one thing I definitely advise is stretches and quadriceps strengthening exercises. I think those are the important ones that are necessary for women. I think all these exercises that you mentioned are important. Sometimes I think people stop walking because of knee pain, and we have to just encourage them to walk. Of course, acute pain, we tell them don't walk, but otherwise, the more they walk, the better the blood flow, the better, less stiffness. So they actually feel better. So even walking for 10, 15 minutes, 3 times a day within the house is better than no walking at all.
Would you advise joint replacement if they come with is it for all? Or would you wait for some time?
No.
I think this is a question for the orthopedic.
Orthopedics.
I think all our questions got exchanged. I'll let Dr. Sendil answer this.
Joint replacements, we keep it to those patients. Actually, we treat the patient as a whole. So if the patient is having severe pain and is they used to enjoy like going to a temple, they're not able to climb the stairs, find it's very difficult to move from one place to another. For them, I think for them, joint replacement would be the answer, because the nerve endings which are there in the exposed cartilage is taken away and it's replaced with a prosthetic joint, so they don't have much pain after the procedure. So it's not for all, because of some people who have health hazards. So basically, some people like comorbidities are very high, and or if the patient is very, very obese, for them we actually kind of do not go in and offer joint replacement as a solution. But yes, if the patient has all the parameters and if they have quite severe arthritis in their knee and like they have deformities and severe pain, then we offer it.
So chronic knee inflammation that prevents a woman from doing a regular activity, maybe you can help them. And what are the tips that you're going to give for fractures when it happens very elderly? Usually this Rammas and Appas who are in their 80s and they had a fracture, and I was going to treat them.
Yes.
How to take care of them.
So these are the fragility fractures, the elderly people who actually kind of because osteoporosis is a silent disease, so you don't have any symptoms. So they complain of a dull ache in the back, and we offer them X-rays in the first, and we see that they have had a fracture. Then once if the pain is really severe, to find out whether these fractures are actually an acute fracture or it's been a chronic fracture, because some of them have had old fractures and have been managing with it. So in those cases, we have to go for an MRI of the. So once we see that it's a confirmed fracture and they are in severe pain, obviously we see the comorbidities also associated with them. If it is more than a month since the time of injury, then we offer them braces to support the back and to prevent them, because once they start getting, especially these fractures in the spine, the chances of getting kyphosis is very higher. So a postural problem. So if they don't, obviously, if the fracture is an acute fracture, for them we offer procedures like vertebroplasty and other things. If the fracture is affecting the hips, which is also very, very common in osteoporosis, for them, we cannot offer conservative treatment, because being bedbound, the chances of other ailments will rise up. So for them, we offer a hip replacement, either a partial hip or a total hip.
Thank you. Do any of the other faculty members have any questions directed towards this expert? They can do so now. Not, we will close the session with profuse thanks from me and the organizers of this.
May I ask a
webinar.
question to the doctor, orthosurgeon?
Sure, madam.
Dr. Sante?
Yes.
Sir, indication for the knee replacement, is it pain or the joint? Hello, am I audible, sir?
Yeah,
Yes, madam. Yes, madam.
The indication, is it the pain which is more, or the X-ray findings regarding the bone degeneration or joint? So, which one should be the indication, sir?
No, X-rays. We don't go by the X-ray findings. The X-ray findings are we don't go by the X-ray findings. So it's only the patient's symptoms. If the patient has severe pain and if the X-ray findings are also correlating with that pain, then we offer them joint replacement. If you have a patient with pain and the X-ray does not correlate with that amount of pain, we offer them other modalities of treatments. So conservative means of treatment nowadays, we offer, if the patient is a younger patient with less amount of arthritis but severe pain, we go in for biological treatments nowadays. We go for stem cell therapy, stem cell therapy, platelet-rich plasma, those kind of things. And we are getting good results with those. So obviously before that, we do a cartilage study, see how bad the cartilage is. And once we do that, we offer them other modalities of treatment like arthroscopy if there is a proper cartilage problem, before we actually kind of offer them any other surgical. So joint replacement is not the only solution. We offer conservative treatments first before we actually go in for any kind of surgical procedures.
Thank you, sir. Thank you.
Thank you, madam.
Thank you. Thank you.
And for the formal vote of thanks, I would invite Dr. Mala.
Yeah. Thank you so much, madam. At the outset, I would like to thank Chennai Menopause Society for this excellent, very, very, very pertinent webinar, Bone Health at Midlife and Beyond, because it is very rare to cover these topics. And as doctors, I think we do not have much knowledge on this thing. It was very beautifully crafted webinar, which would be of great, immense use, not only to all the specialists, but also to our general gynecologists who keep dealing with all these women in their day-to-day practice. I would like to thank our chief guest, Dr. Lakshmi Shrikante, madam, and Dr. Sandhya Dixit, madam, for honoring us in this webinar and blessing the webinar by being the chief guest and guest of honor. And also immense thanks to our president of Chennai Menopause Society, madam, Dr. Shanti Gunasingh, madam, who's been doing a very, very phenomenal task by organizing various webinars like this, and also very ably supported by our two duos, that is the Secretary of Chennai Menopause Society, Dr. Meera Raghavan, and our eminent treasurer, Dr. M.G. Dhanalakshmi Madam. And of course, I would also like to extend a heartfelt thanks to our chairpersons, Dr. Jaya Vijayaraga Madam, Dr. Vijaya, and also Dr. Anuradha Madam for their valuable time in chairing these session, and also very excellently spoken evaluation and screening of the bone health by Dr. Bharani Vijayaraghavan, and also work ergonomics for doctors were a mandatory one, which is very unlikely for us to address all these topics. And of course, our very eminent endoscopist, Dr. Jayashree Gopal, on highlighting the calcium, vitamin D in midlife and beyond, very, very pertinent topic. And also a beautifully moderated panel by our treasurer, Dr. M.G. Dhanalakshmi Madam, and also for ably supported by our chairpersons and experts chairperson, Dr. Kalaivani Madam, and experts to share their knowledge on this very pertinent topic, Dr. Jayashree Gajaraj Madam, the past president of CMS, and also Dr. Nirmala Jaishankar Madam, the president of OV, and also Dr. Senthil Kamala Shekaran sir for highlighting on the orthopedic point of the bone health, and also again ably supported by Dr. Jayashree Gopal Madam. I will also extend my thanks to our MOC, Dr. Rajalakshmi, and also our coordinator, Dr. Divya Ravikumar, and also like to thank all our delegates who attended the webinar, and our Shield Farmers for supporting us with this excellent platform. And it is my great honor and privilege to deliver this vote of thanks. Thank you so much.
Thank you, Mala. I would like to announce the results of the quiz.
Yes, ma'am.
So that will be so Meena has come first, and followed by Dr. Padma Ravindran. Okay. So I congratulate both our CMS members for having got 5 out of 5. So congratulations. So thank you.
Thank you, ma'am.
Thank you so much.
Thank you, madam.
Thank you.
Thank you, ma'am.
Thank you, madam.
Thank you so much.
Thank you. Thank you, ma'am.
Madam.
Thank you,
Thank
ma'am.
you,
Shanti and